Welcome, everyone. I'm Mark McAdoo from SourcEdge. Our thought leadership series, Health Plans, Technically Speaking, takes us to the exciting topic of value-based care. And trust me when I tell you, there's no one better to talk about this exciting topic than our special guest, Lili Brillstein, longtime colleague and dear friend. Welcome, Lili.
Thank you so much, Mark.
Lili, I thought it would be helpful for our audience if you could sort of share a little bit about your journey in your career, sort of starting in the world of public health, and then transitioning with a groundbreaking value-based care program with Horizon, and now more recently in your role as founder and CEO of BCollaborative.
Yeah, well, first of all, thank you for having me, Mark. I'm so happy to be here. And you're right. So my career did start in public health. I did a lot of work around domestic violence and HIV discrimination, and actually never, ever anticipated working for health plans. Never was part of my goal or my plan. And after spending about 10 years on the provider side at what is now Northwell Health, I did end up on the payer side and spent about 20-ish years working almost exclusively with providers. I did spend about 20 years on the payer side, and in all of my roles really worked with providers to get them more engaged with the payer, which, as you know, is not always an easy thing to do. When I was at Horizon, which were the last 7 years I spent on the payer side, it was a wonderful opportunity I had there to really kind of take the experiences I had from public health and working on the provider and the payer side and build the specialty care value-based program at that plan. And what was really wonderful about it was not only was the model and the program successful in terms of improving patient outcomes and reducing costs of care, unnecessary costs of care, but the providers loved it. They absolutely loved the model. They became our ambassadors for the program. They came with ideas to expand the program, and we kind of became their trusted advisors, which is somewhat unheard of, right, between payer and provider. And one of the ways I really worked to grow that program was to get myself as smart as I possibly could. I spent a lot of time talking to people, listening to people,
Right.
Asking questions, sharing the successes I was having and the challenges I was having. And I think lots of people thought they were learning from me, but really I was secretly gathering all the information I could and bringing it back to my program.
I knew what you were up to. I knew what you were up to.
You did know, and you were such a great early partner with Health QX. And so anyway, the program became really successful. Lots of payers sort of were paying attention and trying to figure out what to do in this space. And I would meet monthly with my Blues brothers and sisters to talk about, what they were doing, what we were doing. And so in 2019, I thought, wouldn't it be interesting if I left the health plan side now that I really understand kind of how things work, what's important to payers, and work with providers and tech companies and pharma and startups and other groups who are interested in supporting this move to value-based care and help them understand what it is that payers are looking for as partners, how they can really interact with them, and how to successfully create a partnership. So that's what I do now with BCollaborative. I work with all of sort of various stakeholders to really help them express their value in a way that payers can understand and work really to leverage the expertise of stakeholders across the continuum.
I'm so excited for you and the launch of your new company, BCollaborative, and you're off to a fantastic start out of the market. I wanted to sort of jump right in and maybe dive in a little deeper about the Horizon story for our audience. I mean, it's just an incredible success story, likely the most successful value-based care model in the country, continues to expand. What was really the key to success? Why is it, and why was it so successful? I know you started sort of as an innovative concept, and then you were able to bring it back into the health plan and really scale that into a strategic division within Horizon. Why was it so successful?
It's such a great question, Mark. And I really think the spirit of the program and the model and the way we sort of approached it, it was the key. So what I mean by that is health plans have historically built programs, built models, and then presented them to providers, and without their having really input or created anything together. And were typically surprised when the providers didn't like it or didn't think it was this successful or think it was a workable program. In this model, what we did was we didn't invite providers in to talk about decisions we had already made. We invited them in to help us actually make the decisions. And
Right.
I used to say to my team, literally, as I had my hand on the door of the conference room to go in, I would turn around and say, everybody, let's forget our need to know everything and all the answers. We're going in here to sort of talk to our partners and ask them, how do we create success? Talking to the doctors from a clinical perspective, they understand what success looks like in the space better than a payer does. That's not the payer's expertise.
Mhm.
So I think really the spirit of the engagement was a key to the success. The other thing I think is, as I think about payers and their number one priority, right? It's predictability of cost. That's
Right.
always the number one priority. And so there's always sort of an inclination on the part of the payer to shift the risk as quickly as they possibly can.
Right.
And I know you've heard me say this lots of times, right? I sort of liken shifting risk too early to getting into an airplane with a pilot who hasn't first been in a simulator, right? The pilot, that plane could crash and I could get hurt or die, right? And the same thing if you shift the risk before your partners really understand how to work in this new environment, how to read the data, how to identify the opportunities, who are the best partners. And so while I had my executive leadership continuously saying to me, get them to risk, get them to risk, get them to risk, they were willing to listen and trust when I said, let's not put them at risk yet. Let's actually level the playing field. Let's take away that fear that we're trying to, get them or do something that isn't really in everybody's best interest. Let's create a model that sits on a fee-for-service chassis, allows the docs to continue to get paid the way they understand, and the payer knows how to pay that way. Give them the opportunity to work with us to read the data, understand the opportunities without any downside risk. And as you know, because you've been in the audience for years when this happened, I used to get heckled right around the country.
That's
People
right.
would say to me, why are you building models that don't have risk? They're not going to be successful. And when finally I was able to say, this is we're seeing outcomes improved, and it's a multi-million-dollar savings model with nobody at risk yet. People stopped heckling then.
That's right.
And what happened was, as the provider partners began to understand the data, see who the best, most effective and efficient partners were, which they really had never seen before because they never saw the data.
Right.
They were able to use that information to get smarter, create success, and then they came to us and said, now we're ready. We're willing and ready to take risk.
Right. So that transparency and that spirit of partnership and collaboration, I think, really made all the difference, it sounds to me. And I know I was involved with you for many of those discussions with your providers. I wanted to ask you, while not in the technology business, you recognized early, I think, with your value-based care initiative with Horizon, that technology was a critical component. Can you share with us a little bit about the role that you feel that technology plays in helping both, let's say, Horizon as well as other health plans scale and operationalize their value-based care models?
Yeah, it's critical. And as you know, Mark, when I got to Horizon, we had there was some technology, some things in place that weren't really working so well for us. And the plan, just like many other health plans, really is not nimble enough to be able to sort of configure the algorithms that would identify what is and is not included in an episode, what services, what individuals are excluded. They're not researched that way, and their systems aren't flexible enough to do it, right? They sit on a fee-for-service chassis. And so when we put the RFP out, and you were up against, HealthQX was up against some big organizations as well as some other startups. And really, we were looking for a place to be able to take our big mess of claims data and send it out and have somebody run it through the jelly bean sorter, if you will, and figure out what are the related costs.
Is that a technical term?
That is a technical term, since we're technically speaking. But what was so interesting, so the technology was key. It allowed us to take the data that we had in our house and really sort it and share it in a way that that looked at all of the care being rendered to that patient, and what was happening, really where are the variations in the care and the cost of care among clinically similar individuals. And I think you probably remember that there were lots of people at Horizon at that time who were concerned about the fact that we were going to engage with a small startup, right, with HealthQX, as opposed to a big, established organization. The thing that was I think, so great about it was Horizon, like most health plans, is not nimble, right? People usually laugh when I say that because it's just so crazy. There's nothing nimble about health plans. But the startup, the HealthQX, was able to be very nimble with us, was able to, we had direct communication, we had fast response, there was the ability to sort of make changes in real time. And that was very important for us as we were really launching and getting up to scale. Very important.
Yeah, it seemed like it was essentially the perfect confluence of events. The market being a little more ready for value-based care engagement, and some of the technology and cloud-based technology catching up with the business. I wanted to ask you a little bit about an article that you wrote. I have it I read, of course, in the November Clinical Pathways. Title of the article is "Engaging Payers in Specialty Care-Based Models." So the world has changed a bit. We've moved through the pandemic. We're now into value-based care clearly having significant momentum. So how do providers effectively engage with payers around these specialty care models?
Yeah,
and maybe share a little bit of your sort of insight from the article, which was terrific, by the way.
Oh, thank you. You know what? The world is different. The world of value-based care is different in this post-pandemic, or the pandemic hangover, as I kind of refer to it, than it was before. What I have seen happen, and I know you know this, but just for the benefit of those listening, part of what I do is spend a lot of my time talking to payers, as much as I possibly can, right? Sharing with them what's happening around the country, what I see, but also trying to understand from them what is happening in their houses. What are their challenges? What are their priorities? And so before the pandemic, we had a lot of pretty mature primary care models in value, right? We had PCMH models, and we have a lot of ACOs where the attribution is based on primary care. Those models are somewhat different than specialty care, right? They're preventive in nature. There's an expectation that you'll spend money in the short term to get to benefit in the long term, right? You bring people in for flu shots and mammograms, and bring them in for care. In specialty care, it tends to be different. The models are really about sort of people who are clinically similar in some way, and addressing the variations in care and cost of care. In the pre-pandemic period, we began to see some more engagement and movement in the specialty space, right? Payers starting to dip their toes in. And it really, most of the models began with procedural episodes. So hip and knee replacements, surgical procedures, they made perfect sense. There's lots of them. There's a lot of variation in care and cost of care. They're kind of one and done. You come in, you have your surgery, you go out. It's a clean time frame. And metrics are pretty easy to identify and measure. And again, so I started to see lots of momentum in that area before the pandemic, and I began to see some real interest in building models around chronic conditions, right?
Yeah.
What happened during the pandemic was, in the sort of second year with the Omicron portion of the pandemic, payers, almost everyone overspent their premiums. And right when people started to come back and there were to healthcare and there was a lot of hospitalization, there was all sorts of utilization that had not been planned for, projected. And so where that happened, and then we have the financial sort of market that we're in today as well, contributing, sort of affecting this space as well. And so what I've seen happen is a bit of a step back
Yeah.
from payers in terms of their willingness to come into this space, and particularly willing to come into this space where there might be expenses up front for return in the long term. I see much more today sort of concern about how do we get to an ROI more quickly? How do we make sure that we can sort of count on revenue coming in right now? So one of the things I talk about a lot with the groups that I work with is in expressing the value that you bring to a provider in this particular market, you want to be able to focus on what's important to the provider, to the payer, right? Which again is always it's always predictability. And they're still very concerned about chronic conditions. Payers understand that they have a lot of variability there, a lot of high cost, and they don't really have the expertise or the in-house expertise to manage it. So they're looking for partners, but they're looking for partners who can identify short-term ROI while they continue to work towards longer term. So for example, if you are trying to work in a particular chronic condition and you're looking at outcomes that might really not come into effect until a year from now, are there things that you're addressing that can bring an ROI in the shorter term or bring change in the shorter term, like a reduction in visits to the ER, like a reduction in admissions, things like that?
So it sounds to me, your assessment of the market, and I tend to agree, while a recent survey of health systems executives, I think it was 55%, it was a Health Insight survey, felt that value-based care will continue to grow post-pandemic, even more so than before. But on the payer side, we're sort of dealing with a show me a now return, show me a short-term return, less of that longer-term view that I think we saw before the pandemic, where health plans were willing to invest in chronic episodes and longer-term return on investment. It feels to me, and it sounds like what you're saying, is that payers are becoming much more focused on shorter-term ROI, which makes it really important for those emerging growth companies and early stage companies to be able to demonstrate an ROI with their platforms in value-based care. So I guess my next question is really, where are we in the world of value-based care? I often refer to you as the bellwether of value-based care. So many people talk about the progress we've made, and I always like to chat with you about what's the reality in the field. It sounds like the interest is there while slowing down a bit, but where's the action right now in value-based care?
So I think, I'm not sure it's slowing down. I think it's just shifting a little, but here's what I see is happening. I see this at CMMI and the commercial payers across the country. Because a lot of payers have primary care models that are pretty mature, up and in place, and many of them are total cost of care models.
Right.
The big discussion happening around the country at every one of these payers is, how do we actually now take these models for primary care, total cost of care, and integrate specialty care, understanding that specialty care is probably the biggest portion of their spend, and in many cases hasn't really been addressed yet. How do we integrate that care and identify who really is responsible for producing the outcome, who has the impact, and from the payer's perspective, how do they not double pay, right? How do they make sure they sort of incentivize appropriately for the outcomes that they're seeing? I see that as that is a conversation that's happening really across the country, and is one that we really need to be solving for. The other thing I see is I do see a continued interest in chronic conditions. You know, one of the things that the pandemic did do for us was it sort of escalated the use of virtual tools to collaborate and create care models, and that's actually been very good, right? Like there's lots of docs now don't necessarily have to just partner with whomever is the most proximate to them, that they can partner with those who are most effective. And with the data they get from the plans, they're able to actually make better assessments. So I see moves in that direction. I also see understanding that we need to integrate behavioral health in with our physical medicine models, that addressing behavioral health care actually reduces the manifestation of physical disease. I think the other thing I would say is, actually, I don't know what the other thing I was going to say.
Well, you know, I was going to chime in and say, you know, you and I have had the great fortune and opportunity to work with a leading behavioral health technology company, Neuroflow in Philadelphia, and it's been just great collaborating with you and sort of helping that executive management team position and sort of enhance their platform in terms of where it fits in value-based care. I definitely would say, you know, you were the pioneer in really looking at the combination of the medical episode combining with the mental health side of the total cost of care. And I think it's really fascinating that your viewpoint, I think then, and it's proven to be true now, if you don't manage the mental behavioral health side of a patient, the medical costs will continue to expand and grow. Can you share with us a little bit about your approach around combining episodes with mental health and also social determinants of health? And I also think that really stems from your background in public health. You've always had this vision of how do we combine social determinants of health to help in the total cost of care around value-based care. Yeah,
you're so right. It really does my public health heart good, right? To be working in this space in that way. The incorporating the behavioral health component into the physical medicine episodes was one of the hardest things I've had to do in my career. And the reason, and it was a huge failure the first time we did it. We had to go back and reassess it. But I think it's so important to talk about the challenges and failures, right? That's where we really learn. What happened, the reason it was so difficult was we were looking to the docs who were managing, in this case, IBD, right, inflammatory bowel disease, so Crohn's and ulcerative colitis. We knew that there were lots of behavioral health components to that disease state, and lots of individuals who were not having that care rendered or treated or even having been identified. And so, since they saw the GI doc most frequently, that's sort of their primary point of contact, if you will. The idea was to create a model where the screening would happen in that practice, in the practice of the physical medicine doc, and then they would help sort of transition the individual patient to a certain cadre of identified behavioral health providers who had some expertise in this particular area. What happened was the physical medicine docs sort of began to, they felt as though they were being asked to deliver the behavioral health care, as opposed to helping partner and transition the individuals. And so we had to reboot several times to really, get to this model of partnership. And again, I think that speaks so much to what's happened in fee-for-service, right? In fee-for-service, we pay for units of care with unit cost payments. And that's what we get, right? We don't see a lot of
that's the behavior, right? Yeah.
And partnership. And so it's kind of uncomfortable, and nobody really knows how to do it. And if you suddenly ask, them to partner with other providers, they don't necessarily really know how to do that. So I think it's just part of the learning curve.
Mhm.
And we were able to successfully relaunch that. And, subsequent to that, there certainly are models like Neuroflow, and others in the space who've really been able to, I think, effectuate good change, and help. One of the ways I think about value-based care is we start with the outcomes. What are the outcomes we're trying to get to? And, why are they so variable? What are the drivers? And then how do we actually address the drivers? And so much of what drives variation, I think, in the individuals with chronic conditions is about adherence to protocols, adherence to
Mhm.
medications, no ability to get where they're going, all sorts of barriers, and that have behavioral health and other components. And we really need to sort of begin to bring them together as a kind of a whole.
Yeah, no, that's terrific. And it's so interesting that the early work that you did is now really the standard. I mean, it's now totally accepted as the standard that you have to treat the mental health aspect of care as part of the medical care in a combined value-based care model. So again, I think that has moved into the standard. Lily, I've worked with you a long time, and you always have so much energy, and you're always so passionate about the work you do in value-based care. But honestly, I don't think I've ever seen you as excited as you are in your new role as founder and CEO of BCollaborative. And I know you have a passion for working with early stage founders and CEOs, and I can see you smiling now and see how excited it makes you. And it's sort of taking everything that you've done in your career, from public health to the payer side, from consulting work, and bringing it all together and helping these emerging growth companies with so many aspects of how to create a better product to support value-based care, how to communicate more effectively with payers and providers. So I thought it'd be helpful and interesting to the audience to hear a little bit about the work you're doing out there in the field with your great constituents of companies that you work with.
Oh, Mark, thanks. You're right. Like, I am having so much fun. I really am having so much fun. This is the first time I've really ever worked with startups, and it's fantastic. It's whereas in corporate America, often it's a lot of form over substance. In these startups, it's all scrappy and substance over form, and I love that.
Yeah.
What I also really love about doing this work with the providers and the startups is the commitment they all have to building models that are really clinically meaningful, that will really address all of the issues that their patients are having, or their providers. Where I feel like I am able to sort of help them understand that while we need to build models that are clinically meaningful, they also have to be able to be administered by a payer. Otherwise, it doesn't matter how clinically meaningful it is, right? It won't be deployed. And so, so a lot of the work that I do is, whether it's with providers or with startups or other organizations, is really around helping them express their value in a way that can be understood by the other partners, right? And so I do I thoroughly enjoy it, and I feel like these are groups that I know they might have been presenting to me when I was on the payer side. And I'll tell you, I probably have said this to you before, but every week, startups or different organizations would come in and pitch ideas about how they could solve all of my problems, right?
Right.
And half the time I had no idea what they were talking about, because they couldn't say it in a way that really made sense to me or resonated with me. And so knowing that, and part of me thinks maybe I was on the payer side all these years so I could figure out how it works, and now come out and share it with others. Here's how it works, and here's how you have to present your story. So a lot of what I do is really help in that way, help identify the issue. Not that the groups themselves don't understand the issue, but to be able to speak it in a way that makes sense to a payer, right?
It's so important. You're right. It's so important. There's no better time, I think, than now to be, with an early stage company, founder, CEO of technology companies. I think payers are more open now than ever to work with early stage companies because of their nimbleness, how agile they are. And I know you get frustrated when you're working with a great company with a great technology or a platform, and they're unable to get to the next level with those discussions because of their sort of inability to simplify the message and show the return on investment. We talked earlier about health plans are now hyper focused on ROI in the short term. And so I'm guessing for your clients in the early stage world, helping them develop, with the great platforms they have, what's the return on investment and what's the sort of elevator pitch that's going to resonate, when you do get an audience, because the payers are busy, they have a lot of priorities. And when you get there, you've got to be on your game.
Yes, exactly right. And, one of my favorite tools really to develop is sort of a one-page document. And it's a very hard thing to do, right? To take all of the, most of these models have a lot of complexity. They have a lot of multifactorial sort of aspects to them. And you need to be able to create the elevator pitch, as you said,
Yep.
in a very compelling, succinct way. And so I love to get it on I say to my groups, I want to get this on one page, and there needs to be a whole lot of white space on here. It can't be filled with, with words.
Single space.
Right, exactly. It needs to be a lot of white space. And there are a few things that need to be there. One is, what is the issue, that you're solving for? And that issue, a lot of groups understand the issue they're solving for from a clinical perspective or a social determinants of health perspective, but they can't, or they haven't articulated it in a way that sort of speaks to that predictability of outcomes and predictability of cost to the payers. And if there's only one thing that I leave, your audience with today, it's that's the number one priority for payers. And so to be able to identify the issue in a way that is compelling, so speaks to that, identify what's driving that, and then identify how your tool or your program impacts those drivers, right? So that you get to the outcomes that you addressed in the issue. And then the last thing is, what is the very, very small lift you need from the plan in order to be able to get it off the ground?
That's right. Oh, that's very, very important. I mean, to the extent you don't have to engage a health plan's IT organization because they're quite busy and they're stacked up with, to make it a light lift, as you say, is absolutely critical. One interesting thing you and I talk about with some of the emerging growth companies we both work with, and some of their conversations with their payer partners, is this propensity to take on risk as the software or technology partner. We're seeing more and more companies that are selling a business model to a payer that says, we'll go at risk with you. We'll have a shared savings model or an at-risk model. Can you share with us what you're seeing out there in the market around essentially technology, early stage companies taking on risk with payers?
I do see that happening. And again, to my earlier point, I'm not a huge advocate of taking risk too early.
Right.
That said, the market we're in today is different than the market we were in pre-pandemic. And so to the extent that a group is able to take on some piece of risk, even if it's a small piece of risk, makes you much more attractive to a payer. Particularly if you're able to put whatever you get paid at risk, or some piece of what you're getting paid. Like if there's new costs that the plan will incur as a result of the activities you're taking on, if you're able to put that piece at risk so that the plan understands the goal and to achieve shared savings, but it won't cost, you're almost guaranteed. Some people call this guaranteed savings, which is not what it is. It's, it's a guarantee that you're not going to increase their costs if you don't get to the outcomes you said you would get to. I think groups have to think about it very, very thoughtfully about what and actually take on. I mean, you know more about financial risk, really, I think, than anybody I know. But I think if a group is able to do it, it certainly makes them more attractive to a payer. And again, I don't think you have to go at full risk. I think a show of faith that you have confidence in your own model
Yeah.
and your own ability to achieve the outcomes goes a very long way.
So it's kind of an interesting parallel to the early discussion we had around payer provider collaboration and risk taking. And your message then was, be careful, go slowly, take steps to get to more and more risk, but don't jump in right away. And I think there's a great parallel to that message with these early stage companies. It's take some risk, but be careful, start small, and then grow the risk-based model over time, because there is a significant amount of financial risk with some of the models that are out there on the market today. Wanted to kind of quickly shift gears and move into kind of the land of CMS and get your perspective as you look ahead to 2023. I mean, CMS with the bundle payment, BPCI and BPCIA were the early pioneers in value-based care models, which then became adopted by the commercial payers. What are you seeing from CMS, and are there any exciting developments that you see for 2023?
Yeah, so CMI, right, the innovation arm of CMS is, their new ACO REACH model program begins in January, and really the commitment there is, or the goal is to really create an ACO-centric model, total cost of care model. And so they're struggling, they're working now to figure out the same thing we were talking about earlier. How do they take the specialty care models and integrate them into these models that are attributed based on primary care? So I've actually had a number of meetings with the team at CMMI. The spirit there is great. They really want to sort of support these sorts of partnerships. But they're having the exact same conversation that the commercial payers are having, which is, how do we do this? How do we figure out who's really responsible? What's the flow of money? Who gets the credit for the the improved outcomes? So they're very much aligned, I think, in terms of what's happening in the commercial market in that way.
Right. No, that's great. That's great to hear. And likewise, I guess I'd ask, as you look ahead to 2023, maybe on the value-based care and the more of the commercial market, what sort of exciting new ideas are you seeing out there, or new potential models that you predict may come to fruition in the next 12 to 18 months?
What I'm seeing, what's really kind of exciting is I've had plans reach out to me, and not only plans, but all sorts of groups reach out to me to say, we really want to partner with payers, with providers, with pharma, with tech, with community-based organizations. We really, that hasn't really happened before. And so to be able to bring together groups that typically, sort of butted heads and couldn't really fathom the possibility of partnering, are now starting to think that way. And that's going to be a huge change. The other thing, and a wonderful one, I think, the other thing I see more of happening for 2023 is this focus on chronic conditions. I think we're going to start to see more models. I really, my view on chronic conditions is they sort of sit somewhere between the PCMH and ACO models and the bundled payment model, or the episodes of care model, as I typically refer to them, which is, kind of finite. People who live with chronic conditions, it's not one and done. They're not in and out. It's ongoing, like primary care, but they're typically not cared for by a primary care doc. Their principal point of contact is a specialist. And so I see new models coming, like potentially a specialty care medical home kind of model that is a bit of a hybrid. I see and hear lots of interest in figuring out how to sort of navigate the chronic space.
Yeah. Well, Lili, I can't tell you how much I appreciate you taking the time to spend with us today. You're an absolute delight to work with. We have a great time working together with clients, advising early stage entrepreneurs. And I mean, you've had such an impact in the world of value-based care, and for you to take some time to share your insights with us is just terrific. And I can't thank you enough. For those of you listening, you can gain more insights on topics like this at our website at SourcEdge.com. And with that, I'll say thank you again, Lili, and take care.
Mark, thank you so much.
Great.